Position, we have now agreed as a regional health economy to move forward with a regional T-health programme. And what this schematic demonstrates really is at a very high level how we see that working. Basically, the way it works is you have a hub, and the hub is a physical place where all of the people who are connected to your system are triaged and assessed. If I put that one up, it's probably a little bit clearer. So if you imagine a patient in Hull who's got COPD, and it's felt that that patient would benefit from having an installation. What this does is it puts the equipment into their own home. It's a very straightforward installation. We have a technology pathway which is around broadband, so you're able to both do the sensing, the monitoring bit, and you can do the video consultation if you require it. That patient is then able to call the centre, the hub, 24 hours a day, 7 days a week, whenever they have a problem. Now, it's our experience of patients with long-term conditions that they are very expert. They know when they don't feel very well. Hello, you know, they've had this condition for some time. So the proposition is that those patients are able to access advice, and we have three levels of triage that we put behind that. The first level is algorithm-based, the second is a specialist nurse, and the third is about this patient might need to have a consultation with a specialist, and we want to network up specialists in the region to provide that support. So one of the phrases we use here is it's scalable local deployment. So the energy, the fizz, if you like, is all about local people wanting to do something better for their patients. And the challenge is you get to a point where actually managing the deployments that you've got becomes a challenge in itself. And we reckon that by enabling that to be scaled up, you can get the benefits of scale and allow for local deployments at the same time. So that's the sort of basic proposition, and there's lots of capability this allows us to offer. Between hospitals, there are critical care facilities that we can network together in this way. We can link primary care into secondary care. We can get rid of outpatients, don't need outpatients for lots of patients. We can put primary care in touch with primary care. We can put patients in touch with primary care. So there's lots of potential capabilities that this system offers. Just a word about T-consulting. There's, in addition to having that consultation with the doctor, we went to see some patients in Denmark who are discharged home 48 hours post-admission, acutely unwell. So they're still unwell. They're 48 hours post a really big crisis. And I remember seeing this lady. She was 83 years old, blind, never had any previous contact with any technology at all. And we were allowed to sit in on the consultation with this patient. And bearing in mind she's very unwell, she's sitting up, she's got her oxygen in her nose, she's got a lipstick on because she's on the telly, and she's got one or two of her friends coming round. And the conversation that takes place is about, I don't feel very well this morning. Okay, let's have a look at some of your readings. Have a look at the readings. They're all in range, actually. If you feel a bit uncomfortable, just turn your oxygen up for an hour, and we'll come back to you in an hour and see how you're doing. Okay, you can see the patient beginning to relax and feel less anxious. The patient then said, actually, my home help hasn't been in today. Okay, we'll get straight on to that. So suddenly this patient, if you compare that to the, if you like, the current system, that patient sitting at home thinking, I don't think I'm very well. They get more and more anxious, the home help hasn't been in, something happens, they ring 999 or they ring for help, and that patient's going to end up in the system. They don't need to be there. If we look at this teleconsult piece, it does a number of additional things in addition to having that interaction with the doctor. So in the bubble on the left, you have the patient at home in contact with their GP or with their secondary care specialist. They're having this conversation, but son is 90 miles away. Would love to be in that conversation, but can't because he's busy, he's at work. But he's sitting at his desk and he's dialed in, and he's part of the conversation. and can ask all those questions that he would just want to know. Do I have to be up this weekend? What kind of support are we arranging? Is it okay if we do this? All those questions get answered. Now, the system that we're designing will allow that doctor, in addition to having the consultation, to say to the patient, now, I think you need some further education about how to use your nebulizer, and I'm going to run that down the system into your telly. So we have a TV set-top box over which this takes place. So this is TV-based rather than PC-based. And the doctor can then send from the central server a program called How to Use Your Nebulizer. The patient can then watch that as many times as they want. It's like Sky. You just go to channel 19, it's your diabetes channel, or a COPD channel, and they watch that video, and they can get their friends around, and they can all have a look at it as well. And they learn how to use that nebulizer. Now, all the research about long-term conditions shows that if you can educate patients about their condition, they do better. Here's a way that we can improve their access to information about their own illness. The other really important dimension is this one, which is about flow management, because part of the problem in the system at the moment is that it's hugely risk averse. So people are just not prepared to take any chances. And understandably enough, so at every point you're given the choice, it's always, well, you better admit if you're not sure. What this system allows us to do is to intervene in that escalator that leads to utilisation of healthcare resources inappropriately, and give patients more control, more choices, more options, and prevents a lot of the unnecessary flows. So how is this going to get used? This is a ridiculous diagram, but it's true. Patients with long-term conditions are by far and away the largest users of healthcare resources. You're 19 times more likely to use healthcare resources if you've got 3 or more long-term conditions. And you might think, well, how can you possibly have 3? You can have 5. Often patients do. They have a touch of COPD, they have heart failure, they perhaps a touch of dementia, maybe they've got diabetes on top. This is not uncommon. And those patients are the patients that use the health service more than any others. So if you think about that, that's where all the money currently goes. What can we do to make the way that money works more efficiently?